So same symptoms, different representations requires a different intervention.
So I was wondering how you go about working with patients who might be coming in with like patellofemoral pain or like patellar tendonitis, because my previous mindset was like taught like just load the knee, load it and reload it. And after like listening to you and your model, it's like that's not always the case. You might need to pull them back and yield, or you might need a different strategy.
Yeah.
How do you go about working with when you've got like 6 weeks or 10 weeks, a minimum amount of time with someone? Like you can have a young kid versus like a geriatric patient. They might have the same measurements. How do I go about like, okay, I'm going to load that person versus I'm going to work on relative motions. Maybe they're elite athlete.
Mm-hmm.
Is it because I don't want to broaden make a population. I want to treat it like n equals 1. But like when you only have that limited amount of time, how do you differentiate and go about that?
Okay. So let's start with a simple representation. I'm punching you repeatedly in the face and it hurts. And so your treatment strategy is, I'm just going to punch you harder in the face and that will solve the problem. Okay. How's that working for you?
Probably not good.
Okay. So is load the strategy?
No.
So what is the strategy that you're trying to reacquire to alleviate the problem at the knee? What is the principle that you're trying to
unload them?
Okay, not necessarily. Okay, if you have a progressive tendinopathy, so a change in the connective tissues, okay, that is associated with load. Okay, we kind of know that, right? And that doesn't mean that we can't use load in the strategy as part of the solution. What most likely you're trying to do, though, is to alleviate the byproduct of the perpetual load, right? So I have tension on a tendon, or I have compression on the anterior aspect of the knee under most circumstances. So number one, do I have normal relative motions available to me? That's step one, because I don't know what the solution will be. I can't, my x-ray vision's not very good anymore. I'm old, right? So I can't see inside, but sometimes we can. Sometimes we get the nice little MRIs or whatever that'll show you like the sort of like the core of the tendon has, the tissue related changes, right?
Mm-hmm.
But the point is like, why would you use load? Well, you're using the load to create a yielding action at the knee in a tendinopathy situation. That's why the parameters of the loading are important, right? So I can get the tissue behavior, right, that they don't have available to them, right? So I have a tissue that has either reached its endpoint of yielding, and then therefore I get a tendinopathy, or I have a tissue that is in a stiffened position to such a significant degree that they start to get the tendinopathy symptoms.
Right. Okay.
Okay. So you have to restore relative motions first and foremost. And then you say, well, okay, then what happened? Okay. Do I need to do something that is more structural? And so this is where the tendinopathy research can be useful. Right. So it was Jill Cook and it's not Chris Barr, is it? I can't think.
Are you talking about where he stuck himself? That one?
No. Anyway, it's just there's a couple of people that are more into the tendinopathy research than other folks, and they've got some protocol related stuff where they're using load on the tendon. So they're ignoring the representation of whether you have relative versus non-relative motions. First and foremost, they're just looking at the histological changes that are associated with loading strategies. So there's information on that if you need it. But the point is first and foremost, it's like alleviate the strategy that is perpetuating the tissue related changes or the symptom, which is number one, restore relative motion, kind of like we always talk about, right? That might be enough to reduce the signaling from the knee, and then therefore you don't have pain anymore, right? If you still have, the tendinopathy based symptoms, like, so you restore all your relative motions, that doesn't really alleviate the symptom, and you might need to try to influence the structure, or you're trying to influence just the pain related relationship, right? So do you ever do like an isometric load on a knee, and they get analgesic effects from that, right? And so maybe you're doing it for that reason, but don't load for load's sake. Load with an intention. It's like, so I put a load on a tendon and I hold it there long enough, and then I get stress relaxation of the tendon, which is actually the yielding action that's associated with the tendon behavior. So if I didn't have the yielding action before, and that was the limiting factor because my tendon was too stiff, guess what happens to the symptoms? The symptoms get better. See it? If it's under perpetual load and it is in a yielding position already, and I restore relative motions, now I took the perpetual yielding strategy away, and the knee gets better. Do you see how you, like, literally, I have to be able to identify what strategy is in play so I know what strategy to use to alleviate the symptoms. Do you see the difference?
Yeah, that makes sense.
So the problem with diagnosing people with patellofemoral pain or anterior knee pain is it's vague. What it says is it hurts there. It says nothing of the why. Okay, that's why you can't go to the files and pull out here's your patellofemoral program, right? Because you have no idea what the problem is.
Right.
So using a structural reductionist model under this circumstance is dangerous, right?
So you were saying there's about you mentioned two different ways. You said it could be in a yielded position, but under load.
Yes.
So would that mean, say, the tibia is internally rotated relative to the femur under load, so it can't fully extend, and therefore it's loading that patellar?
So under that circumstance, it would be in an extended position, wouldn't it? If it's tibiofemoral ER relative to the femur?
No, tibiofemoral IR relative to the femur.
Okay, well, good luck with that. That's going to be really horrible and painful. That would be somebody that had tibiofemoral ER and then the whole system ER'd.
Tibiofemoral.
They would look like they have a varus knee.
Got it. Tibiofemoral, that would be a varus.
It would look like a varus knee.
So what would it be if it's in a yielding position but under constant load? I'm thinking yielding.
That's literally what you just described.
Okay. And that, so in that case, I mean, like everything else, you would want to restore full relative motions first, and then.
Yes, sir.
And in that case, it would be getting that full knee extension. So femoral internal rotation and tibial external rotation, but working the way down from the hip.
Yeah. Okay. Look at the relationship between the VL and the VM under these circumstances, Jordan. Okay. So let's go through this for a sec. Okay. So let's say that you're looking at the knee and you identify the tibiofemoral relationship. And so you have a proximal femur IR relative to you have a distal femur IR, proximal tibia ER. Okay. The screw home, right? So that's an extended knee. Under those circumstances, okay, the VL will be concentrically oriented relative to the VM. Do you understand that? Because of the twist. Okay. Would that concentric orientation under these circumstances increase the tendon stiffness, or would it take it towards end range yielding? You got a 50-50 shot. Here's the coin flip. You ready?
End range yielding.
You had a 50-50 shot and you blew it. Okay. This is why gambling doesn't work. Don't be a gambler. Okay. Think about the position. So the knee is already extended. So everything on the anterior knee is in a shortened position. There's no way that you're going to reach the end range yield. Okay. Okay. Now hang on. Now, so think about this. So VL is an internal rotator. So it already internally rotated the femur. So it's concentrically oriented. I probably have a really, really stiff looking tendon under these circumstances. I'm going to have limited knee flexion. Oh, you see it? You see it?
Okay.
Okay. All right. Now, let's take the whole system now. So start with that same orientation, but now twist the entire leg into external rotation. If I do that, okay, I got a VL that wants to be concentrically oriented, but the twist that's coming from proximal to distal from the hip down is going to pull on that VL, isn't it? Right. So this is weightlifting for the VL. This is why you get those people with the one big thigh and the skinny other thigh. So the VL is lifting weights all the time. Okay. It's getting pulled against its desired position. So it's going to start to hypertrophy like a mother. But the position is twisted outward. So it's going to pull the tendon with it. So now I'm pulling the bowstring back and I pull the tendon long. And then I hit the end and then they come in, they say, Jordan, I got pain in the front of my knee. And you go, wait a minute, the orientation is different than what I expected before. So now I got somebody that's end range yielding. Okay. Do I want to use a loading strategy that's going to produce yielding on that tendon? No. Do you see why you would use one approach in one situation and the other approach in the other situation? Do you see it? So same symptoms, different representations requires a different intervention. You get it?
Yeah.
Yeah.
That makes a lot of sense now.